lecture series. This is part 4 on tachyarrhythmias. Okay, so you're faced with a deteriorating patient and this ECG. How do you interpret it in order to guide your management for this patient? Well, firstly, some definitions. By tachycardia, we're talking about heart rates greater than 100. The treatment of these conditions is going to depend on a couple of things. The first being, is the patient hemodynamically compromised? So is their blood pressure dropping? Is there evidence of decreased end organ perfusion? So for example, if the brain were underperfused, are they lightheaded? Are they dizzy? Or are they completely unconscious? And as well as that, even in the absence of hemodynamic compromise, the treatment will depend on what type of tachycardia they have. And so that's what we're going to talk through in this lecture, identifying the different types of tachycardias. Now you're going to identify it by looking at a couple of things, and the first one is the QRS complex wide or narrow? Okay, that's extremely important when you're interpreting these conditions. Then you're going to look at regular versus irregular, and you're going to try to identify the P waves. So after you've done those three things, checked whether it's wide versus narrow, regular or irregular, and assess the P wave, you'll use those details to work through a list of differential diagnoses. Okay, so I've got a list here, which is what we'll be working through. There are a few things that aren't included on here, but this has got certainly the most common tachycardias. So straight away we divide the list into narrow complex tachycardias and wide complex tachycardias. So some examples of narrow complex tachycardias would be atrial fibrillation, which is obviously irregular, atrial flutter, sinus tachycardia, AV-nodal re-entry tachycardia, AV re-entry tachycardia, and these two are different in that the re-entry circuit in AV-nodal re-entry tachycardia is entirely contained within the AV node, whereas in AV re-entry tachycardia, at least some part of that circuit does not involve the AV node. Okay, so for example, Wolff-Parkinson White, where there's an accessory pathway at some other part of the heart that's not part of the AV node, that would be a type of AV re-entry tachycardia. Anyway, there are other examples of narrow complex tachycardia which I haven't put in this list, but this will do for now. And the point is, in all of these cases, the initial action potential starts in the atria and travels down through the AV node, through the bundle of His, the bundle branches, Purkinje fibers, and conduction through the ventricles is essentially normal, and you get a narrow QRS complex. Comparing that to the tachycardias on this side, the pathophysiology in this case all results in wide QRS complexes. So first thing, the first one on this list, the first one I want you to think of every time you see a wide complex tachycardia, it's got to be ventricular tachycardia. Now there are other options, but the first thing I want you to think of every time you see a wide complex tachy is VT. Now in ventricular tachycardia, the action potential started in the ventricle itself, and so it doesn't follow the usual conduction system. It spreads through the ventricle more slowly, and as a result the QRS complex is wide, so you get a wide complex tachycardia. There are some other options though, so for example supraventricular tachycardia with aberrancy. So what I mean by that, by aberrancy, what I mean is some sort of issue with the conduction system. So for example, let's say a left bundle branch block. So you could have a supraventricular tachycardia, such as atrial fibrillation. Alright, the atrial fibrillation drives the tachycardia, but then because there's also a left bundle branch block, well that left bundle branch block makes a QRS complex wide. So you end up with a wide complex tachycardia, but the origin of that tachycardia is different, okay? It's supraventricular in origin, even though it's wide complex in that case. As our final example over here, we've got supraventricular tachycardia with pre-excitation. So in certain circumstances, Wolff-Parkinson White syndrome, for example, can give rise to a wide complex tachycardia, but we'll talk a bit more about that in a different slide. So we're trying to identify the type of tachycardia, and to do that we're going to try to identify the origin of each beat. And we've talked about this before, okay? So in sinus rhythm, we know that the action potential starts at the sinus node, and so the P wave should be upright in lead 2, inverted in AVR, and if there's normal conduction, then they'll all be followed by QRS complexes. Alright, so P wave and QRS morphology is key to this. And so we've seen this slide before. Sinus beats will have the normal P wave followed by the QRS. Atrial beats will have an abnormal P wave followed by a QRS, a normal narrow QRS. Junctional beats, well, the P wave might be absent. It might occur just before or just after the QRS, but the point is we still have narrow QRS complexes with junctional beats. And with ventricular beats, well, there's no P wave because we're starting in the ventricles, and then we have a wide QRS complex. Okay. Now, if you see these patterns in your tachycardia, well, you've just identified which type of tachycardia you're dealing with. Now we're going to talk through a couple of examples. Okay, so what's this tachycardia? How do you interpret this ECG? Well, firstly, is it wide or narrow complex? I think we'd all agree it's narrow complex. Is it regular or irregular? Looking across the rhythm strip, it looks pretty regular to me. So this is a narrow complex tachycardia. And what about the P waves? Well, we've got P waves before every beat. And as well as that, they're normal sinus P waves. Okay, they're upright in lead 2, inverted in AVR, and each one looks the same, so this is sinus rhythm. This is sinus tachycardia. What about this example? Once again, wide versus narrow. So it's a narrow complex, regular versus irregular. Let's say it's regular. So we have a regular, narrow complex tachycardia. What about the P waves? I can't see any clear P waves in this ECG. So which type of beat has no P waves? If you remember back to that slide, 2 slides back, junctional AV-nodal beats have no P waves, at least sometimes. So this is a AV-nodal tachycardia, maybe an AV-nodal re-entry tachycardia. So this is a type of SVT. Right, what about this one? Right, once again, we've got narrow QRS complexes. It's irregular. And are there P waves? Well, I can't see any reliable P waves. There's not a P wave before every beat, that's for sure. And we've got quite an unstable baseline in V1 as well. So this is atrial fibrillation. We're going to talk about this one in a little bit more detail. So in atrial fibrillation, the key pathophysiology here is that we have disorganized activation of the atria, okay, and that's termed fibrillation, so it's atrial fibrillation. Because of that, there's no P waves, okay, there's no organized atrial activity to form a P wave, you just have this disorganized, random activation of the atria, okay. And this disorganized activity leads to an unstable baseline because there's always some sort of random atrial activity happening. Because of this irregular activity, we have irregular activation of the AV node and bundle of His, and so we have an irregular ventricular response, or irregular ventricular rate. The ECG features you need to be aware of: an irregular rhythm, okay, the first differential should be AF. As well as that, if there are no P waves, an unstable baseline. Now this might be very fine, sort of irregular waves in the baseline, or it could be quite coarse, and we term them fibrillatory waves. If it's just simple AF, then QRS complex should be narrow, because after all, once we get to the AV node and bundle of His, all the ventricular conduction will be normal, and so we'll get a normal, narrow QRS complex. This is the most common sustained arrhythmia, and the treatment of AF is something that's worth knowing a little bit about just because of how common it is. Okay, and you can break down the treatment into rate control, rhythm control, and long term we've got to think about stroke risk and anticoagulation. So it's worth being familiar with the CHADS-VASc score. But that's beyond the scope of an ECG lecture. It's just something I recommend you read up about. So here's our example of atrial fibrillation. As you can see, it's irregular, So not only is it irregular, there's no sort of grouping here. It's not like we've dropped every third beat. Okay, the QRS complexes aren't grouped together in some way. It's just irregularly irregular. There are no P waves that can be seen in this ECG, and we've got an unstable baseline, most prominent in V1, and that's often the case in AF. V1 often is a good spot to see that irregular baseline. It sometimes will look like P waves. So if V1 is the only place that you can see P waves, and the rest of the ECG is irregularly irregular, I'd be pretty suspicious of AF in that case. Here's another ECG. How do you interpret this one? Alright, first thing when you're interpreting a tachycardia, is it wide or narrow complex? This is a narrow complex tachycardia. Okay, next, is it regular or irregular? This one's pretty regular. So we have a regular, narrow complex tachycardia. Can we see any P waves? Yes, we can. But these aren't normal P waves. For a start, they're negative in lead 2. Alright, so it's not going to be a sinus rhythm. As well as that, there are a lot more P waves than there are QRS complexes. Okay, so there's some degree of AV block in this case. Now, this is atrial flutter. Atrial flutter is caused by a re-entry circuit in the right atrium. Now, this leads to an organized atrial activity, which causes P waves. But because they're not coming from the sinus node, they're not going to be normal P waves. Okay? So they're not going to be upright in 2 and inverted in AVR. They're not going to look like that. They'll have some other abnormal morphology. The atrial rate in atrial flutter is usually about 300, and there's often a 2-to-1 AV block, leading to a ventricular rate of 150. Having said that, it's not always a 2-to-1 block, and it might be a variable block. So this isn't always a regular tachycardia. It can be irregular if there's a variable block. The ECG features for you to be aware of: it's a narrow complex tachycardia. It might be regular, it might be irregular. The ventricular rate is usually around 150, with an atrial rate of 300. And the flutter waves, that's how we would describe the P waves in atrial flutter. So the shape is often described as a sawtooth pattern, and that's best seen in the inferior leads 2, 3, and AVF, although it might resemble a normal P wave in V1. So let's have a look at an example here. So here we've got a narrow complex tachycardia, and really the giveaway in this ECG is the sawtooth pattern that we've got in the inferior leads. Now, you'll notice that these 2 QRS complexes are closer together than these 2. So we had a bit of a varial block in this ECG, and you can see it in some other places as well. My point being, it's not always a rate of 150, it's not always a regular tachycardia. But when you see this sawtooth pattern and a narrow complex tachycardia, then that's the giveaway that it's atrial flutter. Wolff-Parkinson White's a pretty interesting tachycardia. It's a AV re-entry tachycardia, not AV-nodal re-entry tachycardia, because the re-entry circuit is not entirely contained within the AV node. It's due to an accessory pathway that allows conduction of the electrical impulse into the ventricles at some site other than the usual AV node and bundle of His. Okay, so somewhere perhaps in the wall of the atria, the electrical signal is able to spread into the ventricles without passing through the bundle of His. Now this is called pre-excitation, and it leads to the delta wave, and that's the key feature that you need to identify on the ECG. So let's go through the ECG features. We've got a short PR interval. Now the reason for that is the AV node usually holds up the electrical signal. Okay, it pauses the signal for a little bit, allowing the atria to finish contracting, and then the signal spreads down into the ventricles. In Wolff-Parkinson White, we've got this accessory pathway, and the accessory pathway doesn't have any such regulation. It doesn't hold up the signal at all. So while the AV node is waiting, the accessory pathway just starts to conduct, and so the QRS complex begins early. So the PR interval will be short, less than 120 milliseconds, so less than 3 small squares. You can see in this case it was about it's about 2.5 small squares. When the accessory pathway starts to activate the ventricles, it does that not through the bundle of His and the bundle branches, it does that through some random part of ventricular muscle, and so the signal spreads muscle fiber to muscle fiber, and it does that slowly. So you get the slow, slurred upstroke at the start of your QRS complex, and that's termed your delta wave. And there it is there. But after that, the AV node, which as you know up to this point has been delaying the electrical signal, once the signal makes it through the AV node, well, it quickly travels along the bundle branches and into the ventricular muscle, and using the normal conduction pathways, it's quite quick. And so you get your normal narrow QRS complex. So you start with a slurred upstroke here, and then you get the normal QRS complex on top of that. The delta wave might make the QRS complex just a little bit wide. It might be 110, greater than 110 milliseconds, for example. And this slightly wide QRS complex is going to have associated ST and T wave changes. The tachycardias that arise from Wolff-Parkinson White are due to this re-entry circuit that's formed when you have the accessory pathway. So what I mean is, what could happen, the electrical signal could go down through the AV node, through the bundle of His, and then it could come back up through that accessory pathway. That would excite the atria, and the whole signal would repeat itself. It would go back down through the AV node, up the accessory pathway, down through the AV node, up the accessory pathway, and this repeating cycle then causes a tachycardia. It could also happen in the other direction. It could go down the accessory pathway and up the AV node, and the re-entry circuit could work like that. But as you can see, the re-entry circuit isn't entirely contained within the AV node, and so it's not an AV-nodal tachycardia, it's a AV re-entry tachycardia. Here's an example of Wolff-Parkinson-White syndrome, and hopefully the delta waves are a little bit more clear on this slide. As you can see, there's a slurred upstroke of the QRS complex here. It's slightly wider than usual. We've got associated T wave and ST segment changes, but really it's these delta waves. That's the key feature to diagnosing Wolff-Parkinson-White. To finish off the narrow complex tachycardias, we'll briefly talk about supraventricular tachycardia, or SVT. Now this isn't a specific diagnosis, okay? Technically it includes any of the tachycardias that originate above the ventricles, okay? It's supraventricular. And everything that we've talked about so far has been a type of SVT. Having said that, you wouldn't really use this phrase if you already knew what type of tachycardia you're dealing with, okay? So if you knew it was a sinus tachy, then you would just say sinus tachycardia. If you knew it was atrial fibrillation, you'd just say atrial fibrillation. The real use of this phrase is if you've been presented with an unwell patient who's deteriorating, and you're looking at their ECG and you see narrow QRS complexes, well, narrow QRS complexes, you know it can't be a ventricular tachycardia, so therefore it must be a supraventricular tachycardia. And at that point you get on with treating the patient before figuring out exactly what type of tachycardia it is. Having said that, when people say SVT, they sometimes use it to imply AV-nodal re-entry tachycardia, AVNRT. The ECG features to be aware of: it's a narrow complex tachycardia, although if there is another conduction defect, such as a bundle branch block, then you can end up with a wide QRS complex, and so you'll have a wide complex tachycardia even though the electrical activity is originating in a supraventricular place. Okay, it might be atrial fibrillation or something else. And it might be regular or irregular, and that's going to depend on what type of tachycardia it actually is. Okay, so atrial fibrillation will be irregular. Sinus tachycardia should be regular, for example. And so here's an example of it. We've got a narrow complex tachycardia. This one happens to be regular. There are no P waves, and so we could call this supraventricular tachycardia. Okay, it's definitely an SVT. It can't be a ventricular tachycardia with these narrow QRS complexes. And in this case, we're going to presume that it's AV-nodal re-entry tachycardia based on the fact that there's no P waves. In this next example, again, we're faced with a tachyarrhythmia. The first step is this wide or narrow complex? I hope we'll all agree this is a wide complex tachycardia. Based on that alone, we should be thinking that this is a ventricular tachycardia. In this case, it's also regular and the P waves are absent, and this happens to be a ventricular tachycardia. Now, important point, whenever you see a wide complex tachycardia in an unstable patient, that is ventricular tachycardia until proven otherwise. It's always great to have some differentials in mind, okay? SVT with a bundle branch block, SVT with pre-excitation, but in an unstable patient, ventricular tachycardia until proven otherwise. And the reason is the medications that you might use to treat these other conditions, well, they can make things a lot worse if you get things wrong. You can't go wrong if you treat as if it's ventricular tachycardia. So unless you're absolutely sure, it's VT until proven otherwise. So the ECG features you need to be aware of with ventricular tachycardia. It's a wide complex tachycardia, and this should make sense to you. It's ventricular in origin, and so the electrical activity spreads muscle fiber to muscle fiber. It doesn't go along the usual conducting pathways, and so it's a wide complex tachycardia. By definition, it requires at least 3 ventricular beats in a row, and if it lasts more than 30 seconds, then we call it sustained VT. Anything less than that is non-sustained VT. We divide it into monomorphic and polymorphic VT. So in monomorphic, there's only one morphology, all the QRS complexes are about the same shape, whereas in polymorphic VT, we have this changing QRS amplitude, and it appears to rotate. So it's also called torsades, and this means twisting of the points. Anyway, what's important to know is that ventricular tachycardia is one of our 2 shockable rhythms. Now, distinguishing ventricular tachycardia from supraventricular tachycardia with aberrancy, so for example a bundle branch block, this can often be quite difficult to do. There are quite a few different criteria that can help to clarify this, but none of them are perfect, and it's really a bit beyond the scope of this lecture. Having said that, I've listed a couple of things here that might be able to help you. So, the first 3, if any of these are present, it pretty much guarantees this is ventricular tachycardia. And the key thing to understand is that even in ventricular tachycardia, the atria are still firing, okay? But they're not going to have any relationship to the QRS complexes. And so the first of these criteria is AV dissociation. If you can clearly see P waves, and they're not related to the QRS complexes, then that virtually guarantees that that's ventricular tachycardia. On the other hand, if you see fusion beats or capture beats, and we'll see some examples in the next slide, that also pretty much guarantees that it's ventricular tachycardia. You could also try looking at the axis, and if it's quite an extreme axis, like a northwest axis, well, that makes it more likely to be ventricular tachycardia. There are lots of other signs that you can look for. It's really quite a difficult topic, and it's not always possible by looking at the ECG. If in doubt, you treat it as VT, okay? If in doubt, it is ventricular tachycardia until proven otherwise. I mentioned on the last slide that it's important to understand that even in ventricular tachycardia, the atria are still firing. Okay, now in that case, occasionally a P wave will conduct through the AV node and bundle of his, and it will land at just the right time that it captures the ventricles. Okay, so here we have an example of one of these capture beats. We've got wide complexes, this is all VT, and then at this moment the P wave managed to get through, and we've got a narrow complex QRS. Okay, so this is a capture beat. And then they go straight back into VT in this case. Down here we've got a similar case, and we've got wide complex, wide complex, wide complex, and then we've got a combination here. We've got a fusion beat. So the P wave has gotten through, but not quite at the right time. It's sort of sharing it with the ventricular focus, the ventricular rhythm. And so we've got this fusion of the narrow complex with the wide complex generating what we call a fusion beat here. It's followed by 2 capture beats, and then goes back into VT. If you see these things in the middle of your wide complex tachycardia, it almost guarantees that it's ventricular tachycardia. I've never been able to capture an example of this myself. People are usually pretty busy resuscitating the patient, too busy to do a 12-lead ECG in these cases, so I've got this example from Life in the Fast Lane, and I will briefly say that I've never seen such an extensive collection of ECGs, and it really is a great online resource if you'd like to do further reading. Here we have another example, and this is of polymorphic VT. So this is Torsades de Pont VT. So what I want you to notice is we go into VT at about this point, and you'll see that the QRS complexes keep changing in amplitude. Now, don't be confused by the abrupt change that we get in places like this, for example, where we move from one lead to another, so from AVF to V3. But even within one lead, you can see the QRS complexes are getting smaller. Probably the smallest one is about here, and then it gets taller again. And it sort of alternates between these higher voltage and lower voltage QRS complexes. And so it's thought to sort of look like a piece of ribbon that's being twisted. And so this is called Torsades de Pont VT, which translates to twisting of the points. And the underlying cause, I suppose, is the ventricular tachycardia in this case is not driven from a single pacemaker. The origin of each beat is sort of rotating through the ventricles, and so the axis sort of rotates with it as each QRS complex originates from a slightly different position in the ventricles. One other thing I'll briefly point out on this particular ECG is that the rhythm strip down here is recorded after the 12-lead ECG. Most ECGs, everything is recorded simultaneously, but this one is recorded afterwards. And so we can see that we were in VT, and then it deteriorated into ventricular fibrillation, which we'll talk about next. I'm sure I don't need to tell you that ventricular fibrillation is a medical emergency, and this is a shockable rhythm. Electrically, the ventricles are activating in a chaotic, irregular manner, and so the ECG shows a chaotic, irregular baseline. There are no identifiable waves, and I'd like to point out that although it is a shockable rhythm, it will quickly deteriorate into asystole, and at that point it's not a shockable rhythm. You can't shock asystole. It may start with coarse VF, and then deteriorate into fine VF, and if you're not looking closely at your defibrillator, that may look like asystole. So if you're not sure, you can actually, on the defibrillator machines, you can adjust the amplitude, and you may then see the chaotic baseline and say, okay, it's still ventricular fibrillation. We might still be able to reverse this with defibrillation, with a shock. But if you leave it too long, it will deteriorate into asystole, and then you'll be following your advanced life support algorithms, which at this point will be CPR, and you can't really shock until you get a different rhythm. So here we have the same example as before. We've got Torsades de Pont VT above, deteriorating into ventricular fibrillation here in the rhythm strip, and as you can see, there's really no identifiable waves, it's just this irregular baseline. That's it for this lecture. Hope to see you in the next one on miscellaneous conditions that you can see on the ECG.